In today's quiz, we will explore antiarrhythmics, drugs used in the management of arrhythmias. The quiz features 10 multiple-choice, scenario-based questions designed to test and enhance your understanding of the topic. Each question offers 5 options, along with detailed explanations for the correct answer and insights into why the other options are incorrect. Be sure to check out the companion video linked in the description for an overview of the key concepts related to antiarrhythmic drugs. So, let's get started. Question 1. Mr. Davis, a 45-year-old male with paroxysmal supraventricular tachycardia, PSVT, is being treated with adenosine in the emergency department. Which of the following is the most likely mechanism of action of adenosine? Option A, blocks sodium channels. Option B, increases vagal tone by activating the vagus nerve. Option C, activates potassium channels in the atrioventricular node. Option D, inhibits calcium channels in the sinoatrial node. Option E, increases intracellular calcium levels. The correct answer is option C, activates potassium channels in the atrioventricular node. The explanation is as follows: adenosine works by activating potassium channels in the atrioventricular node, which leads to hyperpolarization of the cell membrane. This action slows conduction through the AV node and interrupts reentrant circuits, effectively terminating PSVT. Here is the explanation for incorrect options. Option A is incorrect because adenosine does not block sodium channels. This is the mechanism of some class 1 antiarrhythmics. Option B is incorrect because adenosine's action is not primarily mediated through vagal activation. Option D is incorrect because adenosine does not directly inhibit calcium channels in the sinoatrial node. Option E is incorrect because adenosine decreases intracellular calcium levels rather than increasing them. Question 2. Mrs. Wilson, a 30-year-old pregnant woman, is diagnosed with supraventricular tachycardia. Which of the following antiarrhythmic drugs is considered safest in pregnancy for the acute treatment of her condition? Option A, amiodarone. Option B, adenosine. Option C, sotalol. Option D, flecainide. Option E, lidocaine. The correct answer is option B, adenosine. The explanation is as follows: adenosine is the drug of choice for the acute management of supraventricular tachycardia in pregnant women due to its rapid onset of action and excellent safety profile. It is not teratogenic and has a short half-life, minimizing systemic effects. Here is the explanation for incorrect options. Option A is incorrect because amiodarone is associated with significant fetal toxicity and is not first-line in pregnancy. Option C is incorrect because sotalol, although used in certain arrhythmias, is not the preferred option in pregnancy for acute SVT. Option D is incorrect because flecainide is typically reserved for more severe or refractory cases and is not first-line in pregnancy. Option E is incorrect because lidocaine is primarily used for ventricular arrhythmias, not supraventricular tachycardia. Question 3. Mrs. Miller, a 60-year-old female with long QT syndrome, is started on an antiarrhythmic drug for ventricular arrhythmias. She is currently on sotalol. Which of the following adverse effects is the most likely in this patient? Option A, bradycardia. Option B, torsades de pointes. Option C, pulmonary fibrosis. Option D, hypertension. Option E, visual disturbances. The correct answer is option B, torsades de pointes. The explanation is as follows: sotalol, a class 3 antiarrhythmic, prolongs the QT interval, predisposing patients with long QT syndrome to torsades de pointes. This potentially life-threatening arrhythmia is a hallmark adverse effect of QT prolonging agents. Here is the explanation for incorrect options. Option A is incorrect because while sotalol may cause bradycardia, it is not the most likely adverse effect in this scenario. Option C is incorrect because pulmonary fibrosis is not associated with sotalol, it is more common with amiodarone. Option D is incorrect because sotalol is more likely to cause hypotension, not hypertension. Option E is incorrect because visual disturbances are not a recognized adverse effect of sotalol. Question 4. Mr. Johnson, a 62-year-old male with a history of atrial fibrillation and hypertension, presents to the clinic with complaints of fatigue and episodes of dizziness. He is currently taking digoxin, warfarin, and amlodipine. His recent ECG shows atrial fibrillation with a ventricular rate of 110 bpm. Laboratory results reveal a serum digoxin level of 2.5 nanograms per milliliter, therapeutic range, 0.5 to 2.0 nanograms per milliliter. Which of the following is not a potential adverse effect of digoxin toxicity? Option A, nausea and vomiting. Option B, yellow-green visual disturbances. Option C, hyperkalemia. Option D, tachycardia. Option E, confusion. The correct answer is option D, tachycardia. The explanation is as follows: digoxin toxicity typically manifests as bradyarrhythmias or other conduction abnormalities, not tachycardia. Tachycardia is not a recognized feature of digoxin toxicity and is thus the correct choice here. Here is the explanation for incorrect options. Option A is incorrect because nausea and vomiting are common symptoms of digoxin toxicity. Option B is incorrect because yellow-green visual disturbances are a hallmark sign of digoxin toxicity. Option C is incorrect because hyperkalemia is often seen in severe cases of digoxin toxicity due to its effects on potassium handling. Option E is incorrect because confusion and other central nervous system effects can occur with digoxin toxicity. Question 5. Mrs. Smith, a 56-year-old female, presents with ventricular tachycardia and has a history of heart failure with reduced ejection fraction, HFrEF. She is started on amiodarone. Which of the following statements about amiodarone is incorrect? Option A, it prolongs the QT interval. Option B, it may cause pulmonary fibrosis with long-term use. Option C, it is contraindicated in pregnancy. Option D, it has a half-life of approximately 1 week. Option E, it inhibits cytochrome P450 enzymes. The correct answer is option D, it has a half-life of approximately 1 week. The explanation is as follows: amiodarone has a very long half-life, averaging around 40 to 60 days, not 1 week. This extended half-life contributes to its delayed onset of action and prolonged side effects. Here is the explanation for incorrect options. Option A is incorrect because amiodarone does prolong the QT interval as part of its antiarrhythmic action. Option B is incorrect because pulmonary fibrosis is a well-documented adverse effect of long-term amiodarone use. Option C is incorrect because amiodarone is contraindicated in pregnancy due to its potential teratogenic effects. Option E is incorrect because amiodarone does inhibit cytochrome P450 enzymes, leading to multiple drug interactions. Question 6. Mr. Brown, a 78-year-old male, is prescribed diltiazem for rate control in atrial fibrillation. Which of the following conditions is a contraindication for the use of diltiazem? Option A, hypertension. Option B, bradycardia. Option C, stable angina. Option D, chronic kidney disease. Option E, heart failure with preserved ejection fraction. The correct answer is option B, bradycardia. The explanation is as follows: diltiazem is a non-dihydropyridine calcium channel blocker that reduces heart rate by slowing conduction through the AV node. Its use is contraindicated in bradycardia because it can further suppress heart rate and lead to symptomatic bradycardia or heart block. Here is the explanation for incorrect options. Option A, hypertension is not a contraindication for diltiazem. In fact, it is often used to manage hypertension. Option C, stable angina is an appropriate indication for diltiazem, as it improves oxygen delivery to the heart. Option D, chronic kidney disease is not a contraindication, though caution is advised due to potential drug accumulation. Option E, diltiazem can be safely used in heart failure with preserved ejection fraction, though it is avoided in reduced ejection fraction cases. Question 7. Mr. Wilson, a 55-year-old male with a history of myocardial infarction and left ventricular dysfunction, is started on beta-blocker therapy for arrhythmia prophylaxis. Which of the following beta-blockers is not recommended for this patient? Option A, metoprolol. Option B, bisoprolol. Option C, atenolol. Option D, carvedilol. Option E, nebivolol. The correct answer is option C, atenolol. The explanation is as follows. Atenolol is not recommended in patients with myocardial infarction and left ventricular dysfunction due to its less favorable outcomes compared to other beta blockers like bisoprolol and carvedilol, which have proven survival benefits in heart failure. Atenolol's lack of evidence for reducing mortality in these patients makes it a suboptimal choice. Here is the explanation for incorrect options. Option A, metoprolol is highly recommended for heart failure in post-MI patients due to its mortality benefits. Option B, bisoprolol is one of the beta blockers with proven efficacy in heart failure with reduced ejection fraction. Option D, carvedilol is preferred in heart failure for its alpha and beta blocking properties, which improve survival. Option E, nebivolol is beneficial in heart failure with its selective beta-1 blockade and vasodilatory effects. Question 8. Mr. Carter, a 30-year-old male with no significant past medical history, presents with paroxysmal supraventricular tachycardia, PSVT. He is treated with verapamil. Which of the following is the most important contraindication for verapamil use in this scenario? Option A, Wolff-Parkinson-White syndrome. Option B, bradycardia. Option C, hypotension. Option D, heart failure with preserved ejection fraction. Option E, renal impairment. The correct answer is option A, Wolff-Parkinson-White syndrome. The explanation is as follows. Verapamil is contraindicated in Wolff-Parkinson-White syndrome because it can worsen the arrhythmia by increasing conduction through the accessory pathway, leading to ventricular fibrillation. Other agents, like adenosine or cardioversion, are preferred in this context. Here is the explanation for incorrect options. Option B, verapamil is contraindicated in severe bradycardia but not the most critical contraindication in this scenario. Option C, hypotension is a potential adverse effect but is not the most significant contraindication. Option D, verapamil can be cautiously used in heart failure with preserved ejection fraction. Option E, renal impairment is not a contraindication for verapamil use but requires dose adjustments. Question 9. Mrs. Johnson, a 55-year-old woman with ventricular tachycardia, has been started on lidocaine via intravenous infusion. Which of the following mechanisms of action best describes how lidocaine treats this condition? Option A, blocks sodium channels in the inactivated state. Option B, blocks beta-adrenergic receptors. Option C, blocks calcium channels in the L-type state. Option D, inhibits potassium efflux during repolarization. Option E, enhances vagal activity. The correct answer is option A, blocks sodium channels in the inactivated state. The explanation is as follows. Lidocaine is a class IB antiarrhythmic that preferentially binds to inactivated sodium channels, reducing excitability in ischemic or depolarized myocardial cells. This selective action makes it effective for ventricular arrhythmias without affecting normal conduction tissues significantly. Here is the explanation for incorrect options. Option B, beta-adrenergic blockade is the mechanism of beta blockers, not lidocaine. Option C, blocking L-type calcium channels is the mechanism of calcium channel blockers, not lidocaine. Option D, inhibiting potassium efflux is the action of class 3 antiarrhythmics like amiodarone, not lidocaine. Option E, enhancing vagal activity is associated with digoxin, not lidocaine. Question 10. Mr. Brown, a 78-year-old man with a history of paroxysmal atrial fibrillation, is prescribed dronedarone. All of the following statements regarding dronedarone are correct except Option A, it is contraindicated in patients with severe heart failure. Option B, it has a lower risk of thyroid toxicity compared to amiodarone. Option C, it has antiadrenergic properties. Option D, it requires routine monitoring of pulmonary function. Option E, it is contraindicated in permanent atrial fibrillation. The correct answer is option D. It requires routine monitoring of pulmonary function. The explanation is as follows: unlike amiodarone, dronedarone does not require routine pulmonary function monitoring as it has a lower risk of pulmonary toxicity. This distinction is one of the main advantages of dronedarone over amiodarone in atrial fibrillation management. Here is the explanation for incorrect options. Option A, dronedarone is contraindicated in severe heart failure due to an increased risk of mortality. Option B, dronedarone indeed has a lower risk of thyroid toxicity because it lacks iodine in its structure. Option C, dronedirone's antiadrenergic properties contribute to its efficacy in arrhythmia management. Option E, dronedarone is contraindicated in permanent atrial fibrillation as it increases cardiovascular risk in these patients. Conclusion. That wraps up our revision on antiarrhythmic drugs. I hope you found this quiz session engaging and informative. To deepen your knowledge further, consider reading resources like Katzung and Trevor's Clinical Pharmacology, Rang and Dale's Pharmacology, and the British National Formulary, BNF. These references will solidify your understanding and enhance your preparation. Also take note that in this video, any mention of guidelines will specifically refer to those outlined in the BNF. Thanks for watching. If you found this video helpful, don't forget to give it a thumbs up and share it with others. Subscribe to this channel and hit the notification bell so you never miss an update in the series that we are doing. For more learning resources, check the description below. See you in the next video.